is actually dealing with this problem. The title is Should Assist Device Influence the Heart Allocation System? It's Dr. Komoda from Berlin.
Thank you, Mr. Chairman. I've been requested to speak about the question of whether assist device should influence the heart allocation system. At present, the heart allocation system is an urgency-based one. Therefore, it is a question of whether assist device should influence the urgency-based heart allocation system. This slide shows the number of heart transplant patients in our center during the last 8 years. Last year, bridge to heart transplant cases accounted for 60% of heart transplant cases. Ventricular assist devices have already been involved in the heart allocation system. That is, in the last 8 years, 185 patients received a valve primarily and 28 patients received a valve after urgency listing. Yes. In 1969, a total artificial heart was implanted in a human for the first time in the world. However, several days after the implantation, the patient needed urgent heart transplantation. And finally, the patient died after the heart transplantation. At that time, the valve and total artificial heart were not optimal, and a safety net by heart transplantation was necessary. 15 years later, bridge to heart transplantation was successfully performed. And 5 years after successful bridge to heart transplantation, UNOS introduced the urgency-based allocation system. Patients with total artificial heart or valve were classified as in UNOS status 1. And 10 years later, the three-tier UNOS rule was introduced. In the new UNOS rule, patients with valve are listed in status 1A for 30 days. And patients with valve complications are also listed in status 1A. In summary, patients supported with valve is critically ill status needing urgent heart transplantation. And Eurotransplant introduced an urgency-based allocation system for Germany in 2000 after enactment of the German transplantation law. That was 11 years after the introduction of the UNOS urgency-based allocation system. A major difference from the UNOS system was that patients with valve or total artificial heart were classified as transplantable. That means no urgency. When valve complication occurred, then patients were classified in high urgency status. In the guideline for donor heart allocation by German Physicians Association, it is stated that patients with a valve have no urgency for heart transplantation. We can only suppose the reason for the policy of no urgency for heart transplantation in the patient with a valve. The first reason may be that valves are well developed and appropriate health care is available for valve recipients. There are two groups in heart transplant candidates in critical status. In studying these groups, patients who received valve primarily were assigned to group valve prim. Patients listed in urgent status primarily were assigned to the group U prim. Survival rates were compared between the two groups. There is no significant difference in overall survival between the two groups. There is no significant difference in post-heart transplant survival between the two groups. Both paths seem to be similar. Patients without priority for heart transplantation due to valve have similar survival rate to patients with priority for heart transplantation. Do they need priority for heart transplantation? The second reason for the lack of urgency status may be the donor heart shortage. And the valve can be used as a method for a moratorium on urgent heart urgent heart transplantation. The time to heart transplantation from birth implantation is significantly longer than the time from the urgency listing. In group U prim, patient received heart transplantation a median of 27 days after urgency listing. On the other hand, in group birth prim, patient received heart transplantation a median of 264 days after birth implantation. And the ratio of patient heart transplanted in group birth prim is 57%. This ratio is more than that in group U prim. The patient receiving primary birth seemed to make a long detour to heart transplantation. Fair donor heart allocation. Patients to whom a donor heart was not allocated during urgent status were assigned to group U bird. Yes. Survival of this group was compared with that of group birth prim. Survival during birth support in group U bird is significantly worse than in group birth prim. Since 2000, the German heart allocation system has been urgency-based, with HU for urgent heart transplantation and T for elective heart transplantation. Now, most heart transplantation are performed in urgent status. Elective heart transplantation shown by light blue and pink bar graph. An upper class of urgency has been constructed above conventional HU since 2005. In Germany, there is a blackout period for urgent heart transplantation. Of course, during the blackout period, the patient is in transplantable status and elective heart transplantation is possible. However, nowadays, elective heart transplantation is performed in few cases. The pink one. Most transplantation following birth implantation are performed in urgent status. Therefore, patients with a birth should be upgraded to urgent status and then receive heart transplantation. Otherwise, patient must die. This slide shows the cause of death after birth implantation. Multiple organ failure accounts for 41% of death until 30 days after birth implantation. Beyond 30 days after birth implantation, stroke and infection are the major causes of death. During the blackout period of urgent heart transplantation, 17 patients died of multiple organ failure. Even if they received heart transplantation, they would die after the transplantation. Once birth complication occurred, patients were upgraded to urgent status or died of complication. The merit of blackout period for urgent heart transplantation is the elimination of potentially inappropriate patients for heart transplantation. The demerit is death due to birth complication. We compare the survival of group birth during birth support with survival of group U during urgent status. Compare these two groups. There is significant difference in survival between the two groups. In group birth, an initial drop of survival is seen until 45 days after birth implantation. The survival curve beyond 45 days is not so steep. Patients who survived more than 45 days after birth implantation and still had transplantable status were assigned to the group birth 45. Survival of group BAL 45 is similar to that of group U. This means that patients in group BAL 45 are as critically ill as patients in group U. The risk of death of patients after the initial drop in survival rate after BAL implantation is still as high as that of patients in urgent status without the BAL. At present, BRCA period for urgent heart transplantation is of indefinite duration. That is, it lasts until bad complications occur. Our proposal is that BRCA period should be a finite length of time. After some finite length of BRCA period, use status should be given to the patient because they are as critically ill as patients in urgent status with BAL support. During the BRCA period, if patients die, the cause may be multiple organ failure. These patients would not have been suitable for heart transplantation. We say give patients a chance to receive heart transplantation before bad complications occur when they have survived long enough with the BAL. Conclusion. A BRCA period for urgent heart transplantation for patients with the BAL is necessary to eliminate heart transplantation in potentially inappropriate patients and to make optimal use of limited resources. However, this period should be a finite length of time and use status should be given to the patient before bad complications occur when they have survived long enough with the BAL. Thank you for your attention.